Hello everyone, this is Daniel Hanna and I will be walking you through our case for this week. This is week 14, case 11. So the students will be working through a forearm fracture case this week. Initially, the patient presents to the ED with severe forearm pain and swelling that was reportedly due to falling while walking her dog. The patient describes a FOOSH mechanism of injury, which stands for falling on an outstretched hand. While working through the case, the students will discover that the type of fracture sustained by the patient, a nightsticks fracture, does not correspond with the mechanism of injury. Ultimately, the students will discover that the fracture is the result of a domestic violence incident. For this case, we have Jennifer Vincent, a 27-year-old woman who was brought to the ED by her boyfriend. Allegedly, the dog jerked on the leash, which is what made Miss Vincent fall to the ground. She initially tried to treat the injury by applying ice and taking ibuprofen. However, her forearm began to swell, and the pain became worse with time. There is some bruising in the area, but no other associated symptoms or injury. Her past medical history reveals that she has had depression over the past 5 years, seasonal allergies since childhood, and several visits to the ED over the past 6 years for worsening rhinitis, nonspecific abdominal pain, scalp laceration, fractures of her right wrist and rib after a fall, and had acute suicidal ideation in 2017, for which she was transferred to an inpatient psychiatric facility. Currently, she has taken sertraline and loratadine. She has no known drug allergies. She works part-time as a bank teller and resides with her boyfriend of 8 months. She was previously married for 4 years and denies smoking. She does drink alcohol regularly, usually beer or wine, consuming 3 to 4 servings each time. She denies the use of illicit drugs. Her mother is alive and living with hypertension and has a history of drug abuse, although she is currently sober. Her father's history is unknown, and she has a 6-year-old daughter from a previous marriage who is alive and well. So, one of the topics that we're asked to delve upon is the concept of the dimensions of pain. There are 7 dimensions: physical, sensory, behavioral, sociocultural, cognitive, affective, and spiritual. Have the students explore and discuss the importance of understanding the dimensions and how they should interview a patient in order to assess these dimensions. Also, have the students determine why it is important to understand these dimensions in the context of identifying sources of pain. So next, lead the students in a discussion about the anatomy of the forearm. Please note that they should have an understanding of the entire upper extremity, but for the purposes of this case, it is important to include components of the elbow, the forearm, and the wrist. Based on the described mechanism of injury, ask the students what structures in the forearm are likely to be involved. Based on this case, it's obvious that the students should gain an understanding of the bones and joints that are involved with the fracture. Later on, the students will discover that the injury is going to evolve, and the patient experiences an acute compartment syndrome of the anterior compartment. Therefore, the students should learn about what makes up the components of the forearm, including the musculature, the fascia, and the associated neurovascular structures that make up that or may be compromised during the compartment syndrome. So this week, the students will be learning about the anterior arm, forearm, cubital fossa, the palm of the hand, and the wrist this week in anatomy lectures and in their gross dissection labs. They will not get to the posterior aspect of the forearm and dorsum of hand until next week, so take that into consideration as they're going through the anatomy. Next, have the students dive into what injuries are commonly associated with a FOOSH mechanism of injury and allow them to develop their differentials based on that. In adults, this type of mechanism should raise the suspicion of a wrist injury. be it a fracture or a sprain to the carpal bones, a scaphoid fracture, scapholunate sprain, an injury to the triangular fibrocartilage complex, which is referred to as a TFCC, or a Colles fracture, which is a distal radius fracture. There's many more injuries that are associated with a Fuchs mechanism, but thinking of what could be going on here and what is typically going on with this type of mechanism. Next, have them determine what information they would like to gather prior to the physical exam. So the pertinent findings of the physical exam include a well-developed, well-nourished white female in mild distress from pain and appears anxious, but oriented ×3. Taking her vital signs reveals slightly elevated respiratory rate, heart rate, and blood pressure. And there's some erythema and edema present over the left cheekbone. Radial pulses are 2+ and symmetric. There's no cyanosis. One thing that the students should recognize is that the musculoskeletal exam is very limited as the patient is guarded, and any movement of the left extremity that causes any kind of movement of the forearm results in severe pain. The left forearm is extremely tender to palpate, but the upper arm, wrist, hand, they're without any kind of point tenderness. The neurologic exam reveals 5 out of 5 strength on the right and 4 out of 5 on the left for grip, thumb flexion, and splaying of the fingers. Sensory is intact on all fingertips, palm, and the dorsum of the hands. And one thing to note here is when the patient was asked about the erythema and edema over her cheekbone, she just tends to shrug and says it must have happened during the fall. It just happened so fast. So she seems to be just playing it off. So moving on from here, ask the students, what is the significance of these findings from the physical exam? Her elevated vital signs could be explained by pain, but it also raises the possibility of another injury. So for example, a rib fracture. The student should also realize the possibility of an acute compartment syndrome. But in this case, at this point in time, her sensation and pulses are currently intact, but as time goes on, you're going to see that these deteriorate as she does sustain an acute compartment syndrome later on. Based on the patient's description of the mechanism of injury, have the students discuss what they would expect to find on imaging as compared to what was found on the clinical exam. At this point, the students may speculate on the discrepancy between the two. Maybe we'll have to wait until they see the x-rays, but falling onto the forearm is much less common as people try to break their fall with their hands rather than the forearm. Now, it could be that she was holding something, but regardless, hopefully the students at this point are starting to pick up the discrepancies. So Ms. Vincent undergoes imaging of the left forearm, which reveals a transverse fracture, which is indicative of a nightstick fracture. This is located at the junction between the proximal and middle 1/3 of the ulna, sort of at the junction here, as you can see. You can see it on both images. At this point, it would be great to have the students review how to read an x-ray and describe the fracture. So this week, the students will be learning how to read radiographs of the extremities during PCL, so this is a great opportunity for reinforcement. Now see, based on the imaging, see if the students want to revise their differential. A nightstick fracture indicates blunt force trauma, likely due to the individual taking a defensive position in an attempt to protect their head or torso. So the students should also rule out the potential for a crush injury from that blunt force trauma to the associated tissues that may result in acute compartment syndrome. However, at this point, again, she's neurovascularly intact. So at this point, how do the students determine what's the most appropriate next steps? What is the initial management of a nightstick injury? Suspected fractures are initially treated with rest, ice, mobilization, and elevation. However, this is dependent on the type of fracture and any associated complications like an open fracture, open wound of the skin at the fracture site, or like we've talked about already, a compartment syndrome. When should they get an orthopedic consult? Should the referral be emergent, urgent? Should it be priority? Have the students look into this. It would also be good at this point to have the students look into the different types of midshaft forearm fractures. So there are three main types. As you can see here, there's the Monteggia, the Galeazzi, and a nightstick. But the Monteggia and the Galeazzi are not very common in adults. But they're sort of these don't miss fractures due to the associated complications. The Monteggia fracture, the proximal radial head will be displaced, dislocated, and sometimes the clinician will not recognize that the radial head is or should be aligned with the capitulum, and it's not. The Galeazzi is a distal ulnar fracture, and there is injury to the distal radial ulnar joint, so that joint is compromised and unstable. So those should be discussed, but like I said, those two are nowhere near as common as a nightstick in adults. Now, Monteggia is much more common in children. For acute musculoskeletal injuries, it is extremely common to incorporate RICE into the initial management, but it'd be good for the students to dive in and find out what the evidence says. Interestingly, there's insufficient evidence to support its use. However, this may be a good time to consider the expert opinions of the clinicians and thinking about the practice of evidence-based medicine and also any national guidelines that are out there. So maybe at this point, the students have a suspicion that the mechanism of injury and the fracture doesn't line up, and that the patient could be fabricating the story and maybe even hiding something like a domestic violence incident. So it would be good to have the students explore how they would approach a situation like this. There are several evidence-based screening tools available for these instances. The students will actually be reviewing an article that discusses the WAST and the HITS this week. An example of the HITS is included in this faculty guide on this page here. The students should recognize the importance of administering these tools when such a situation is suspected, and they should also be aware that this should be done when they are one-on-one with the patient, or the patient can do it on their own, but just know that the patient should have privacy when they are filling out these types of screening tools. The other thing is that these resources should be offered even if the patient denies abuse. So at this point, this concludes the first day of the case, and we will move on to part 2. We pick up where Miss Vincent is returning from the radiology department. A few hours have passed, and at this point she is sobbing, writhing in pain on a stretcher. She reports that the pain has continued to worsen, is now much worse than she remembers from a previous fracture that she sustained some years back. She also reports numbness and paresthesia in the left wrist and hand, and can no longer grasp a pencil. Upon further examination, the left forearm appears substantially more swollen. The skin is red, very tight. The forearm is very firm to palpation. Her fingers are now held in a position of flexion. She's unwilling to move her elbow actively or passively. Any attempts of passive extension of the left wrist and fingers cause extreme pain. She reports decreased sensation to light touch and pain over the palmar aspect of her hand and fingers. Her left radial pulse is palpable but feels diminished compared to the right. So at this point, the patient is demonstrating signs and symptoms of an acute compartment syndrome. Have the students discuss the significance of these findings. The students should investigate the cause of a compartment syndrome. As part of the discussion, the student should identify the anatomical structures that are involved in this process and why the patient will exhibit the symptoms that she does. So the orthopedic trauma team is contacted for an urgent evaluation for acute compartment syndrome. The diagnosis of an acute compartment syndrome is confirmed based on the findings of neurovascular compromise, and immediate surgical intervention is recommended to the patient. So at this time, it would be good to stop and ask the students, what are some common reasons for compartment syndrome to occur? There are numerous causes. Trauma is by far the most common. And as you can see in the guide, there are several others. Another common reason is placing the cast on too tight, or any kind of dressings like an ACE bandage, any kind of burns, post-ischemic swelling, intravenous drug use, and even in rare cases such as snake bites. So an acute compartment syndrome is brought on by an increase in the intercompartmental pressure of the anterior forearm compartment. In this case, the pressure may increase to a point that is sufficient to reduce capillary perfusion, thereby leading to an inadequate tissue oxygenation of the tissues within the compartment. Next, if the students haven't already, have them determine how this condition is evaluated, including how compartment syndrome is diagnosed and treated. Measurements of the affected compartment can be done using a transducer connected to a catheter, which is then inserted into the affected compartment of the forearm. A critical pressure is considered when the compartmental pressure is above 30 millimeters of mercury. It's also recommended to assess the delta pressure, which is the difference between the diastolic blood pressure of the patient and the compartmental pressure. Fasciotomy is indicated when the delta pressure is less than 30 millimeters. When appropriate, positive clinical findings should prompt urgent surgical intervention without the need for compartmental measurements. Now have the students hypothesize what acute and/or chronic complications are likely if the compartment syndrome is left untreated. Failure to relieve the pressure in time can lead to tissue death in the affected compartment. The most common complication is Volkmann's ischemic contracture, which is irreversible muscle contracture of the forearm, wrist, and hand. There are several other complications, including rhabdomyolysis. Next, ask the students how a fasciotomy improves and possibly reverses the pathophysiologic derangement in the compartment. In returning to the case, the students will find that the surgeon's recommendations for immediate surgery are presented to Miss Vincent and her boyfriend. During the discussion, the boyfriend becomes angry, swears loudly at the surgeon, is insisting that a second opinion be arranged with a real doctor. During this tirade, the patient looks down and says nothing. Eventually, the boyfriend is escorted from the patient's room. After the boyfriend leaves, Miss Vincent seems anxious, afraid. She asks the clinicians then ask if she has ever felt afraid of or unsafe around her boyfriend, and whether he has ever hit her or tried to injure her. And at this point, they reassure her that whatever she says will be kept confidential. Miss Vincent at that time begins to sob heavily for a few minutes and then finally speaking says that her marriage ended because of physical and emotional abuse. And she was afraid of her daughter at that point in time. Her depression came on during the marriage, and at its worst, she attempted suicide with drug overdose. And then currently, with her current boyfriend, he seemed nice at the beginning, but things have recently turned ugly. He lost his job, started drinking heavily, using crystal meth, um, and most recently, with this incident, her menstrual period is 8 days late, and when she told her boyfriend that morning, he exploded, and that's when he began to beat her. He hit her in the face, upper back, left forearm, and that was when she was raising her left arm to defend herself, and resulted in a fracture. And as it can be imagined, she was afraid of being seen for fear that the fight would be discovered, but ultimately she decided to come. So now is a good time to ask the students how the inquiry about domestic violence can be handled confidentially in a sensitive and non-judgmental manner. One of the key points is that the patient should be interviewed alone. Keep in mind that there are limits to confidentiality, which the clinician should make clear, particularly in cases of suspected child abuse and neglect or abuse of a vulnerable adult. If the patient is willing to share their experiences, let them listen and validate their feelings. Avoid any kind of comments that might imply that the patient is to blame. Do not push the patient to express feelings or discuss the details of the violence. It can be re-traumatizing, and always remember that the doctor is not a detective. It's crucial to address immediate needs following domestic violence, which in this case are the urgent medical issues. Following surgery, the patient's safety is the most important need to attend to. There are several questions here that can be asked. Allow the students some time to explore their thoughts. How would they handle both the need for an emergency surgical intervention while acknowledging the patient's psychological and emotional distress? What could happen to Miss Vincent if she stays in the relationship? How should this patient be advised about domestic violence? Just give some time for the students to explore this. After some time, have a discussion regarding the responsibilities of healthcare providers acting as mandatory reporters, and include both Georgia and South Carolina. We're right on the border, so it would be good to include both states. Is there a difference between mandatory reporting requirements for child abuse, intimate partner violence, and elder abuse between states? Healthcare providers are mandated to report child abuse, also elder or disabled adult abuse, and any non-accidental injury. And there's a link here in the Facilitator guide that you can check into. Let the students explore why some states do not require mandatory reporting by healthcare providers for intimate partner violence. Next, ask the students, why was this likely missed, this injury, or not the injury itself, but why was the domestic violence aspect missed during the patient's initial presentation? It may be simply that the exam was too focused. So as physicians and healthcare providers, it needs to be encouraged to find a balance between a focused and a thorough exam and adjust appropriately in different settings. So I'm returning to the case here. While the boyfriend is still out of the room, Miss Vincent agrees to undergo emergent surgery. As the team prepares, she undergoes a more thorough exam, which reveals multiple bruises over her body with large, fresh bruises on her back and thigh. Here, the students should analyze the blood and urinalysis test results. One of the key questions here is to ask why her CPK is severely elevated. In this case, it's because she has developed acute rhabdomyolysis due to the previous trauma and the current compartment syndrome. Again, returning to the case here, after some discussion of the CPK levels and the blood and urinalysis and test results, Ms. Vincent undergoes an urgent fasciotomy to her left forearm with vigorous administration of normal saline. Some of the muscles debrided, because of necrosis and looks necrotic. And the fractured ulna undergoes open reduction and fixation. The wound is left open for several days, after which she undergoes a second operation to close the skin incision. Her sensation returns to normal, as does her forearm strength and mobility. Her left arm is casted or splinted using a sugar tong splint. Depending on the day of the afternoon session, the students may have already practiced applying splinting for the upper extremity injuries during PCL this week, including a sugar tong splint. Regardless, this will be a good time to reinforce their knowledge regarding the steps taken when applying a sugar tong splint. Next, let the students discuss the healing process of bony tissue, including both direct and indirect healing. Just a note, this topic will be lectured on the Wednesday morning of this week. So, following up the discussion of the healing process, ask if Miss Vincent is at risk for developing any infections or osteomyelitis. There are numerous complications that may arise, and the simple answer is yes. So that includes just having an open wound in the hospital. Obviously, closing the wound is also a challenge. And there's really no consensus in the literature regarding the best method for doing so after a fasciotomy. And there's a link here that you can click on and to get more information. At the end of the afternoon session, the students will learn that before Miss Vincent's boyfriend is allowed to see her after recovery, she's encouraged to report the episode of abuse and to allow law enforcement to be contacted. She indicates that she's afraid of what her boyfriend might do. She has provided contact information for the local shelter and telephone number for the National Domestic Violence Hotline. The hospital social worker speaks with her concerning the issue. But again, the physician has a duty to provide an oral report to the designated violence delegate at the facility, and local law enforcement is notified. The Department of Family and Child Services is notified because of physician's concern for Miss Vincent's daughter, who currently lives with her and her boyfriend. Eventually, she is discharged with her boyfriend and scheduled for a follow-up appointment 1 week in the orthopedic clinic. Unfortunately, she misses her initial appointment, but is seen 2 weeks later, at which time her fracture and incision are found to be healing well. This is the end of the case. With some time left at the end of the afternoon session, allow the students to explore the following 2 questions. What might be some problems with a Department of Family and Child Services assessment at the time of discharge, and how else might a physician advocate for patient safety and the safety of their child without involving law enforcement or government agencies? And then the next thing is the Friday morning session, where any leftover learning summaries can be covered, the article review, and then student-led discussions and so on. All right, this wraps up the overview of the case. I hope you all have a fantastic week.